Thank you, Director Orszag. There's several or many significant features to the budget request you brought before us, but none more salient than the one you just discussed, namely health care. This budget creates a health care reserve fund and calls for funding of $634 billion over 10 years. Will that amount of money cover the cost of the proposal that the administration has in mind?
Mr. Chairman, as we described, the Health Reserve Fund is a down payment, a very significant down payment on funding a health care reform.
Is that 50%, 60%?
It's likely to be the majority of the cost, but whether it's 50, 60, 70 will depend on the details of whatever is finally done. And you will hear more about this on Thursday when we hold our health summit, and you will hear more about it as we move through the legislative process. But we are trying to avoid the mistakes of the past in which, we came to Congress, or an administration came to Congress and said, here's the health plan. We want to work with you in an interactive way to get health care reform done this year, and we're putting a significant down payment on the table to get that process started.
Will that include possibly some revenues from auctioning of emission limits and cap and trade?
The budget does propose that, but that is sort of in the energy area. In healthcare, we do have a revenue proposal which would return the tax break for itemized deductions for the top. It will affect 1.2% of taxpayers, return that tax break to the level that existed at the end of the Reagan administration with the revenue debt after 2011 and with the revenue dedicated to health reform.
Can you outline the basic outlines of the health care proposal the administration will send us? Or is it too early to do?
No, well, the budget includes key principles on the health reform. But again, you're going to hear more about this on Thursday. We want to work with you interactively. What we wanted to do in this budget is put some money on the table to get the process started, and that's what we did.
The stimulus bill contained a very significant item, over $19 billion, as I recall, for information technology. That's a substantial sum of money. When you were at CBO wrote a critical analysis of a number of information technology claims to astounding sums of money and debunked many of these. Do you think HI, hospital information, health information technology, is a source of real revenues that will pay dividends and help fund the cost of health care in the future?
Health information technology is necessary but not sufficient by itself to move to a more efficient healthcare system. So remember that map that I put up with huge variation across the United States in how healthcare is practiced. If you look across regions of the United States, you see this. If you look across hospitals within a region, you see this. If you look across doctors within a hospital, you see this. You see very substantial variation in healthcare practices, with the higher cost approaches not backed by specific evidence that they work any better than at least less costly approaches. And health information technology is one of the key ways that we need to flesh out and get the information necessary for doctors to figure out how to practice in a more efficient way. Let me give you two examples. If you look at in the last 6 months of life for Medicare beneficiaries, if you look at two of our leading medical centers, at one of them the average cost is $25,000 a year, at another $50,000 a year, and the quality indicators, if anything, suggest that the quality is better at the $25,000 a year medical center. All that we seem to be getting in exchange for $25,000 a year now, that's your taxpayer dollars, is more tests, more visits to specialists, more days in the hospital, none of which seems to actually help other than raising costs. In addition, if you look within a hospital, it has been demonstrated that if you sit doctors down and say, do you realize, two groups of doctors, that you're practicing medicine in much different ways, they will often evolve towards the less intrusive, less costly approach, but they often lack the data to do that. Most of the data that we have today are based on insurance claims. That tells you what happens to a patient, but not what the result is. Health information technology will help you figure out both what is done to a patient and what the result is, so that medical professionals can figure out more effective ways of practicing medicine.
Now let me turn to defense spending. You showed us what non-defense discretionary will do, namely come down as a percentage of GDP over the next several years. What happens to defense spending over that period of time, the other half of discretionary spending?
Defense spending also declines as a share of GDP. In 2009, it's projected to be 4.9% of GDP, and on average, over the next decade, it's 3.6% of GDP. Secretary Gates has stated that it is time for the Defense Department to begin the process of reorienting its priorities and, in particular, redesigning the procurement and acquisition system to become more efficient. And I am deferring to his judgment in terms of how he does that, but he believes that this budget is a healthy budget for the Defense Department, both in terms of the funding for the troops and in terms of providing the beginning point for starting to turn the ship towards a more effective, especially procurement and acquisition system.
Our analysis shows, I'm not sure we have the chart ready at hand, but our analysis shows that defense spending over the next 10 years under your budget keeps pace with inflation and then some. It's barely above control. There we go. The blue bar being the President's budget, and the red bar being current services, which would be existing defense adjusted basically for inflation and other changes. Basically, the President is just a bit ahead of current services, just a bit ahead of inflation.
That's correct for the base defense budget.
But we're fixing the level of expenditure at a pretty high level historically.
There has been a very significant increase in the defense budget, and this budget, the President's budget, starts the process of improving efficiency in the Defense Department, again, especially in the procurement area.
Now, for supplementals, you're doing away with supplementals, but don't have any numbers for the out years other than the $50 billion plug that you put in the budget after next year. When do you expect to refine that forecast so you can give us the actual numbers that fit into the $50 billion plug?
Well, first let's step back and realize there will be a supplemental submitted this month for this fiscal year on military operations. In the budget, you have details on that. It will be slightly in excess of $75 billion. As you go out over time, as you noted, we have in 2011 and thereafter a $50 billion placeholder for overseas contingency operations. You've already started to see some of the policy announcements coming out from the administration on troop levels, both in Iraq and in Afghanistan and other areas. It will be ongoing policy development that is done to back up what the out-year cost may be. Again, maybe I should have said this at the beginning. We've had 5 weeks in office. The budget process normally takes 5 to 6 months, so we're taking our best guess, our best shot at a variety of things, and there's going to be a lot more detail to come with the full budget in April.
Along that line, and one last question from me. At least in the outline of the budget which we've got here, the Blue Book, there's not a lot of attention given to the long-run sustainability of the major entitlements, particularly Medicare and Social Security. What is the administration's position on those with respect to this budget? Are you looking upon it as something that has to be done outside this budget, separately and independently from it?
I would take a slightly different view, Mr. Chairman. Again, as the chart that I put up shows, the key to our fiscal future, the key entitlement problem is health care. And this budget is going to, we want to get health care reform done this year. And in doing so, we want to do it in a way that will help to reduce the long-term growth rate in health care costs. Health care reform is entitlement reform. If we bend the curve on health care, it's the single most, on health care cost growth, it's the single most important thing we can do to get our long-term entitlements under control. So, to my mind, given that graph that I put up with the rising Medicare and Medicaid costs, it makes sense with health care, which is what we want to do. And then as my testimony points out, after we've dealt with the key to our fiscal future, Social Security also does face an actuarial deficit, and it would be desirable to address that problem after we have dealt with the bigger one, which you can see in this graph is Medicare and Medicaid.